So, good morning. My name is Lindsay Mossman. I'm the Gender Advisor at the Aga Khan Foundation Canada. And this session, just to make sure you're in the right room, is Gender Equality in Practice, Lessons, Insights, and Ways Forward. We're going to be talking about contextually relevant, locally informed solutions to advancing health outcomes and promoting gender equality, including tangible examples of operationalizing Canada's gender equality policy and the Feminist International Assistance Policy. So I'm your moderator. I'm also sort of a panelist and also a timekeeper. So that's a lot of jobs, and I'll do my best. And I will go through the overview of what we're going to cover in this short panel, and then I'll introduce my wonderful co-panelists. So the key questions that we really wanted to think about and unpack during this session are, how can gender equality assessments contribute to both the development and implementation of gender equality strategies, objectives, and interventions in a health project? What are the learnings from putting gender equality strategies into practice, the challenges, the successes, and how do we know we're making progress? How do we sustain the gains made from our efforts on gender equality within health projects? Who needs to be involved? And what are the resources that we need to have in place? And how will these learnings shape our current or future approaches to gender equality integration in health programming? So those are sort of the framing questions that we'd like to cover as much as possible today. So the overview of the session, opening and introductions, we'll do that. And then we're actually going to have two presentations from our panelists, one on the Access Kenya Gender Assessment and one on the PNEP Ghana presentation, and I'll tell you a little bit about those. We'll have a short panelist dialogue, and then we'll try to make sure we have lots of time for audience questions and answers. So just for those of you who maybe are new to Aga Khan Foundation Canada, we're part of the Aga Khan Development Network, focusing on social, cultural, and economic development. And we operate in Kenya, which will be the focus of the presentation today, using a multi-input area approach to development, which means we have multiple sector interventions in Kenya, including in education, health, civil society strengthening, and economic development. The Access Project, which Violet will tell you about, and I'll introduce her in a moment, is a health project involving a number of the Aga Khan Development Network actors, including Aga Khan University, Aga Khan Health Services, Aga Khan Foundation, and Sick Kids, who is also on our panel by coincidence. So it's funded by the Government of Canada and working in partnership with the Government of Kenya, Ministry of Health, and local government. And Sick Kids will talk about a project they're implementing in Ghana entitled Pediatric Nursing Education Partnership, or PNEP, which is a 5-year partnership between the Sick Kids Center for Global Child Health, Ghana Ministry of Health, Ghana Health Services, and the implementing partner, Ghana College of Nurses and Midwives. It's also being implemented with funding from the Government of Canada and the Sick Kids Foundation. So the focus of our presentations today will be primarily to provide background on how these projects have integrated gender equality. In Access, we'll look at how they've integrated gender equality through a gender assessment that was done at the beginning of the project. And for PNEP, we'll focus primarily on gender equality strategy implementation. We're going to focus on lessons learned, insights, and ways forward as part of the discussions. So our panel, with beautiful photos, I might add. So myself, Gender Advisor at AKFC, I'd like to introduce Violet Nanyu, who is a researcher at the Aga Khan University Center of Excellence in Women and Child Health in Kenya, as well as an associate professor at Moi University School of Medicine, among her 15 other jobs. We've been chatting about that. Nikhil Agarwal is the program manager at the Sick Kids Center for Global Child Health, and Michelle Dowling is a project manager at Sick Kids Center for Global Child Health. So I will stop there and pass on to Violet to present to you about the Access Kenya Gender Assessment. Thank you.
Good morning, and my name is Violet, as you've heard. I'm from Kenya, and I'm very excited to be here to share with you from the Access program. And one of the things I keep hearing about in Kenya is the NGO and the CBO. We have too many abbreviations. So just to make sure, I want to make sure you understand what Access stands for. that is access to quality care through extending and strengthening health systems. All right? I'm practicing. I wasn't sure how this works. Now I know it does. So access aims to improve the availability, quality, and utilization of essential health services for pregnant women, newborns, and children under 5. And in Kenya, this access program is being implemented in 2 counties. One is Kisii, and the other is Kilifi. The project interventions focuses on the following things: improving existing selected health facilities. For example, when I went to Kisii, the women kept asking, when is the theater coming? We're losing mothers because they can't make it to the big facility out of town. When are you bringing the theater for cesarean sections? So one of the things we seek to do is to improve existing selected health facilities and actually aligning with the priority needs of the of the Ministry of Health on the ground. The other thing is to improve quality of care by training health facility staff on evidence-based interventions and health facility management practices. And the third thing is health promotion and outreach to improve community uptake of MNCH services. We realize that even if you improve the supply side, if you don't do something about the demand side, you may not end up making the 2 arrows come together. So we're trying to do the demand side work, but also making sure by the time the community health volunteers have informed every household about the facilities and convinced mothers to get linked to care, when they show up, we don't want them to come and find that we don't have drugs, we don't have trained nurses, we don't have anything to offer them. So we're trying to make sure we're balancing both sides of the coin. I was engaged by the Aga Khan University Center of Excellence in Women and Child Health to help with the gender assessment, and we had 3 main questions. And the first one was, how does women's access and control over resources and decision-making influence their ability to actually access this care? The second question they asked me was, what are the social and gender norms around this? Actually, my background is in anthropology and sociology, so you can see why they threw me in that bucket. And the third question was, how is the community already doing something, or how can they actually do something to address gender inequalities in decision-making and in participation with reference to MNCH? And our methodology was mainly qualitative, but we started with, of course, document review, to see what was already known about uptake of care for ANC, the delivery day, and PNC, postnatal care. But we used a lot of key informant interviews and focus group discussions so that we could answer the question why, how, and the challenges people face. So you can imagine, we were seated together over there. When the first panel finished, we were wondering where the qualitative data person was. We kept thinking there should have been someone there. All right, sorry, moderator, I'm deviating. So those were the key things, and let me not dwell too much on the methods, but the key informants, we talked to religious leaders, like the imam from the Islamic, in Kilifi we have the Islamic communities and the mainstream Christian leaders, so we talked to both sides. We talked to chiefs. Here, a chief is someone who is in charge of about 5,000 people in what we call allocation and sub-locations. We talked to assistant chiefs. We talked to leaders of women groups. I remember in Kilifi, one of the group leaders was running a group where they were doing what we call table banking. The women would come with their little monies, put it on the table, and decide who was to take the money that day and go do some good stuff out there to help the household. So we got very interesting women leaders coming together to tell us their stories. We also talked to health providers and Ministry of Health representatives. For the focus group discussions, we made sure we listened to the men and also the women. So we had 16 focus group discussions, 8 at each of the 2 sites where we worked, and with men or with adult women, but we also made sure we had adolescent women. In Kenya, and I've been born and raised there, a lot of girls get pregnant early or get married off early. I am from a marginalized community called the Maasai, and I am not a typical Maasai woman. My age mates got married by the age of 13. My age mates got female circumcision by the age of 10 to 12. I almost got circumcised. It's another long story. I was wishing I was in the other group. Now the two groups are running at the same time. But due to a lot of accidents, my life turned out differently. But really, we wanted to hear stories of these young mothers or adolescent girls who have been married or are potentially going to be married soon. And we also talked to what we call the Community Health Committee. We have what we call community units following the primary healthcare model, and you have a committee running these community health issues in those particular community units. So we wanted to make sure we got all their stories. So we used five main areas of inquiry. The first was access to services. We wanted to understand the barriers that these mothers and their spouses were experiencing when they were trying to get to care for MNCH issues. We wanted to know about resource control and care-seeking behavior for MNCH. Then about decision making, we wanted to know who makes decisions in the households. Who makes decisions about healthcare in the households? Can a woman get up and say, I'm going for A and C tomorrow? What does she need to do that? Does she have access to the resources she needs to do that? So we wanted to understand that women's role in decision making in the household, but also in the community, and other roles that they may be playing. But also we wanted to know about the man's role. We also asked questions about beliefs and perceptions about family planning, breastfeeding, marriage, female circumcision. I avoid saying FGM, female genital mutilation. It already sounds negative. But there's some good side to some of those rituals that go with it, but the cut is not good. Okay, sorry, moderator. So we also wanted to know the beliefs around male involvement, because we realized that there's some beliefs that a man may bring bad karma to the maternity ward, for example. We had already seen that in literature. So we wanted to know in these two sites, what were the beliefs that would affect participation of men? And then for practices and participation, we actually wanted to know about uptake of these facilities, responsibilities, accompaniment by spouses to healthcare. We wanted to know all those stories from them. And then lastly, the fifth arm was on laws, policies, and programs. We wanted to know about messaging around MNCH in the health facilities. We wanted to know about laws and rules and any policies they had. Like in one facility, they said, one of the rules here, when you get to the gate and you have a woman in labor, the watchman, we call them watchmen, that's the gate man. I don't know what you call them in Canada. He is supposed to give her express service. If a woman comes in labor and gets to the watchman at the gate, this was in Kisii, we were told one of the rules that the superintendent of the facility said, that woman should not be asked what's her name, where she's coming from, she's taken straight to maternity. We start with the baby first. So those are some of the things we wanted to know about laws, policies, and programs at the facility, women's participation and governance at the health facility. So I'm going to give you the findings really quickly. First of all, we realized from the study that there are lots of MNCH services available, but they're not available across the board for all households and all locations and sub-locations. There was limitations, especially in postnatal care services. It was to say, oh, the baby came, what else do you want? Go home and dig. So there was a story told in one of my focus group discussions about a woman who came from delivery, and the father-in-law sent her to the market the next day and just said, just wrap the baby on you and go. And the woman who was telling the story was almost cried in the FGD, but she was describing someone else. So you can see a man who thinks, you delivered safely, you're fine, get up and go to work. So the postnatal care services were weak or missing. Operating theaters were not adequate. Ambulances, you had to pay sometimes to get one, and in some places there were no ambulance services. Barriers, when we asked about barriers, we go barriers at individual level, the mother's level, household level, community level, and we also saw the supply side barriers. Just to quickly mention, the barriers at the individual and community level: poverty, religion, lack of transport, literally. There's one bus, it leaves in the morning at 6. Once it's gone, if you didn't go on that bus, you won't get to hospital, you won't get to the market. So those kinds of problems, limited knowledge about MNCH, limited confidence in community health volunteers who are supposed to spur them up into care, previous bad experience at the health facility, late initiation of antenatal care, Spousal decision on how to use funds and getting permission to go for care, and also being too busy with household responsibilities. In my country, first of all, by the way, I am a mother of 6. I work, I cook, I have to take care of my husband. He comes from work, puts his feet up, I go to the kitchen. Seriously. So, and I'm sure there are men and women from Africa here, maybe they can correct me if I'm wrong, but that's how it is in my household. And we still need permission to go for ANC and postnatal care from the husband. So if he's not there, there may be a hitch right there. When you look at the health system factors that we noticed, distance to the health facility, the government in Kenya is trying to make sure every household at least has a minimum of 5 kilometers. A maximum. Within 5 kilometers distance, there should be a dispensary. But a dispensary is the lowest level of care. So if you need specialized care during your antenatal care or the day of delivery, you might have a problem. Remember, the bus leaves in the morning. All right, so distance to health facilities. And right now, one of our postgraduates is actually looking at point of care. They got a grant, Challenges Canada fund to work in Kilifi with those mothers who are marginalized, so thank you very much. So lack of supplies, long queues at the health facility, lack of privacy during consultation. I actually went to one of the facilities in Kisii. There was just a curtain, and the nursing officer on that side and the rest of us queued here. We were hearing all her business. So she would finish, get out, she turns the curtain, and we're all like, oh, that's her. Yeah, that bad. Then there was compulsory shaving of women's pubic hair. That came up, and I was like, oh, tell me a bit more about that. So they didn't like it that they had to be shaved. And some of them said that's the man's role. He should have shaved me before I go to the hospital, because the hospital is going to do it. And you're charged a fee for that. Then abuse by healthcare workers. No services, no special services for women with disability. This was missing in both places that we worked in. And lack of confidentiality in handling information from patients. Now, the other part was decision making. This one I will wrap up real quick. I think I already alluded to it. Men make decisions on key household matters, but women can actually influence decisions on family planning, clinic attendance, delivery, and domestic hygiene. A number of women said they wanted to get implants because they didn't want the husband to know they got it. So they made some decisions on their own, and then later on they would share them. Then spousal involvement was mainly in providing money for transport and for supplies during delivery day or when you're going for the clinics. And they would also follow labor progression, but from far. In Kenya, a lot of people have cell phones these days. So they call and say, oh, is the baby there? Not yet, okay. But they don't come to the health facility, or they use a proxy, the mother-in-law, or their sister, or someone else. So they keep calling that person to get, so that's one of their roles. They reported it with a lot of enthusiasm. That's my role. And of course, the other role they were very happy about is naming the child. It's my job to name the child. As soon as I hear the baby has come, I ask, is it a girl? Is it a boy? Oh, she will be called Violet. All right? They also help mothers remember the visits for the clinic, and they help some of them, the younger men talked about accompanying their wives to the ANC clinic, but not to the delivery. I'll tell you why they don't come to delivery. All right? Oh, mothers-in-law. She's reminding me. The mother-in-law is a very important person in most of the Kenyan societies, including these 2 counties where I worked. In fact, a lot of young men in the 2 counties we worked away from home. So they went into towns to look for money, and by the Kenya is famous for something called M-Pesa. We started a way of sending money through phone. So the young man gets some money, puts it on his phone, loads it, and sends the money, not to his wife's phone. She may not actually have a phone. He may have bought the mother-in-law a phone. So the money goes into the mother's phone, and the mother facilitates the lady to go for care. So she makes decisions about family planning, and whether you go and you don't go, what you eat and what happens to you. In fact, we also came across mothers-in-law who are always, when are you getting pregnant? So they're also interested in, yeah, okay. So men's involvement, I've already alluded to it. This case, I interviewed a leader of a women's, and I want to read it because it came out really strongly and it captures the picture. When we asked about men involvement, one woman said, it's just a custom. He can never go near a woman giving birth. It's a taboo. And the old mothers can't allow a man to come. They say men are not trustworthy. The point was, if a man is adulterous during the time the woman is giving birth and he shows up at the maternity, he jinxed, it's bad karma. She can have obstructed labor, she can die, or the baby can die, and it's a very strong belief. So you don't want to be near the maternity and your wife dies. They're going to say, who have you been sleeping with in the last 24 hours? It's a very strong belief. So some men would like to come, but you can see that we have beliefs we need to deal with if we're going to increase male involvement in from ANC to delivery day and thereafter postnatal care. All right, so common barriers to male involvement, apart from ignorance about the importance of males, because they would say, oh, that's a woman's sphere. What are you talking about? Why do you want a man to be involved? Just that knowledge that it's important. Work responsibilities, okay. 2 minutes. They work away from home, so they are not able to help throughout. Many of them feared HIV testing. They said, if I accompany my wife for the ANC antenatal care, they're going to test me and I don't want to be and then unfriendly health facilities, like what I've described, people assuming they shouldn't be there. Looking at beliefs and practices, people liked having big families, but also there were fears about side effects of contraceptives. A lot of them talked about marriage being above 18 as the correct marriage period to get married, but there were a lot of adolescent mothers. So early marriages were reported, and even as you can see from the lower quote there, parents actually literally using dowry. You have dowry in Canada? During famine, you get a gift when your daughter gets married. So if she's young and you're broke, you just get a marriage going. So that's what I'm saying. Unfortunately, that's been happening. When you look at practices, exclusive breastfeeding was clearly taught and explained by the health facility people. But in the community, the elderly mothers would say, oh, the baby is hungry. Give a little bit of porridge, give a little bit of mashed potatoes. So there was mixed feeding a lot and confusion, especially for the young mothers. And then we had young mothers who had to go back to work and some back to school. And assumptions that the mother is not getting enough food, and beliefs that the breast milk can make a baby feel unwell, and prohibition of breastfeeding when you're having sex. So a woman who's having sex with her husband cannot breastfeed because it's believed it's bad karma again. The breast milk will make the baby sick. Okay. I have only 1 minute, so I can't tell you all the stories. I'm an anthropologist. So lessons learned. Lessons learned. Qualitative research is really useful when you're trying to understand what's going on around gender in the communities, because the why and the how questions cannot be answered using a quant approach. It's good also to have a strong framework, like the way we had the 5 key points that guide the domains of your question guides, and also looking out for voices from across the board, which we were listening to indigenous, to the women themselves, to people from the health facility, to women leaders. So trying to make sure you hear from everybody, and then making sure you conduct the gender assessment early in your program so that you can use that information to do the program in a way that addresses the gender dynamics in the community. Thank you. Thank you.
Well, thank you, Violet, for that very passionate, informative presentation. Good morning, everybody. My name is Nick Agarwal. As Lindsay said, I'm a program manager at the Sick Kids Center for Global Child Health, along with my colleague Michelle, project manager. It was great to hear Violet talk first to sort of really give us a sense of the gravity of the situation. And through our presentation, what we hope to provide you with is a sense of how PNEP is trying to address some of the issues and how we're starting to see some changes in behavior in our programming in Ghana. To start with, let me give you a brief introduction about what it is we're doing. So as Lindsay alluded, we have a program called the Pediatric Nursing Education Partnership, or PNEP, and it's a 5-year partnership between Sick Kids and our local stakeholders in Ghana, generously funded through Global Affairs Canada. And really it's focused on reducing preventable deaths and improving the well-being of newborns and children in Ghana. But as well, it's focused on advancing the profession of nursing in Ghana. And this is done through practice-focused pediatric education. Now, we chose to focus on nurses because they are so essential to the health system. They represent the largest portion of the health workforce. They work at the front line of health service delivery, and they have a particular focus in underserved areas. We have also seen that evidence shows that as you increase the density and the specialization of nurses, it actually results in improved outcomes for children. As Lindsay mentioned, our implementing partner is an agency of the Ghana Ministry of Health, which is the Ghana College of Nurses and Midwives. And by partnering with GCNM, whose mandate is to focus on specialty nursing training, we're really hoping that we can, at the beginning and throughout our programming, integrate our activities and our outputs already into the existing health system to really help build the capacity of our individuals and our stakeholders. So just to give you a sense of the scale and the scope, the flagship component of PNEP was the development of a one-year nursing training course that we refer to as the associate program. And through PNEP, we intend to train 500 nurses by the end of 2020. And this is in support of the Ministry of Health's goal of training 1,500 nurses in pediatrics by the year 2025. PNEP was actually built on the success of a pilot that was done 5 years previous to the start of this program, and we had already trained about 220 nurses in pediatrics through training that was based in Accra only, which is the capital. An evaluation of our pilot showed that it was a very successful program, and it was recommended that this program be scaled up beyond Accra to cover the country broadly. So we've set up sites, as you can see on the map, in the Central Belt, in the city of Kumasi, and in the Northern Belt, in the city of Tamale, to ensure that we're able to recruit and train nurses from all parts of the country. But the impact of the associate program actually goes well beyond the students themselves. PNEP actually engages numerous faculty that includes lecturers, clinical educators, and facility-based preceptors who we all spend time training and building the capacity of as they become faculty of this program. As an example, we engage part-time lecturers who also have concurrent appointments at academic institutions across the country. So they can leverage the knowledge that they've gained in PNEP to also benefit their roles outside of our program. Similarly, facility-based preceptors who oversee our students during the clinical practicum component benefit from very specific preceptor training that focuses on different areas that includes competency assessment and gender-sensitive care, which in turn is a benefit to the multiples of students that they actually interact with at the facility that goes well beyond our program. We've also established a number of partnerships at clinical sites in each of our sites that helps to build the capacity of institutions by ensuring nurses in these facilities have the opportunity to enroll in the program. And as Lindsay mentioned, by partnering with the Ghana Ministry of Health, we can engage system-level stakeholders to ensure that there's real bidirectional learning at a system level, and we can also ensure that our gender-related messaging is very appropriate. So we do align our programming with Global Affairs policy on gender equality, which I won't read to you, but I'll introduce our strategy in a minute. But our strategy closely aligns with these three objectives on decision-making, rights, and access to and control of resources, as well as Global Affairs Canada's new policy on Feminist International, the Feminist International Assistance Policy, and their core action area on gender equality and the empowerment of women and girls. So here you see a visual representation of our gender equality strategy. And just at the onset, I want to mention that our approach is actually to equip our students, or to equip local individuals like our students, as well as different organizations and systems with knowledge that can empower them with the tools to promote gender equality and gender-sensitive care through the health system. So really at the end, we hope that our nurses become leaders in their community and agents of change who really can help improve gender equality and provide gender-sensitive care. So in addition to the three objectives on equal rights, decision-making, and control of resources, we've also focused on our project management activities, where we want to ensure that all those who are involved in our project understand the context and ensure that they are on the same page regarding gender messaging. So we have done this through by conducting a gender assessment at the onset, but also by conducting gender training for our core oversight committees and our key education team members who are based in Ghana using existing online resources such as the Global Health Learning Center. Through our evaluation approach, we've also ensured that gender equality is included in our logic model, and actually activities roll up to one of our key intermediate outcomes, which is improving the application of leadership knowledge and gender-sensitive care. So we collect a lot of qualitative and quantitative data, including rich data from interviews which my colleague Michelle will share to you. And it was great to see the quotes that Violet had presented, showing again the gravity of the situation, and we'll actually shortly share with you some quotes that can hopefully show how some points of view and approaches are changing. And again, just in the interest of time, I won't introduce equal rights decision-making and control. I'll turn it over to my colleague Michelle to talk about those in more detail.
Thanks, Nick. So I'll be speaking about some specific examples of how gender equality is taught in the curriculum. And I'm speaking from the perspective of a project manager, not a gender equality expert, someone who stepped into the role and inherited this strategy and had to learn about it and implement it. So the concepts of gender equality are integrated into every course in our curriculum. For example, while nurses are learning about how to treat a child who's been abused, then they also learn about gender-based violence and its underlying causes in Ghana. Or while the nurses are learning to provide primary care to children and newborns, they'll also discuss the social determinants of health and how gender inequalities contribute to malnutrition of mothers and girls. But a really important tool that we use to integrate gender equality into these courses is case studies. And the aim is to provide students with opportunities to both learn how to provide gender-sensitive care in various situations and also to directly address issues of gender inequality. So let me give you an example. Here we have a young boy admitted to the hospital, but he's refusing treatment and he won't take medication because he's been taught that men should be strong and that they shouldn't feel any pain. Another example is this mother whose child is sick, but her responsibilities at home, farming and taking care of other children, prevent her from bringing the boy to the hospital and getting the treatment that he needs. So I want to go into this second example in a little bit more depth to show you what we go through in the classroom with nursing students. The teacher guides the class through 3 approaches of gender mainstreaming, women's empowerment, men's engagement, and gender synchronization by asking the class a series of questions and facilitating the discussion. So as an example, the teacher might ask, how can the healthcare system remove barriers to accessing care? And some of the responses that we heard from students were that clinics could offer childcare, or that they could move the services into the community, into the home, or into spaces where women usually congregate, like the market. And the teacher also teaches the students how to provide gender-sensitive care. So asking questions like, how should a nurse respond to a mother who is delayed in bringing a sick child to the clinic? Nurses should respect the challenges and the barriers that woman faced to get the child there, affirm her decision to bring the child in, and provide education and resources to help reduce gender barriers to accessing care in the future. A nurse should never blame or embarrass the mother, which unfortunately is a common practice. In terms of men's engagement, a nurse can explain the question that would be asked is, how would you approach a father who comes in with the child? And a nurse can explain the serious health implications of delaying treatment and help the father see that protecting and providing for his family sometimes means being flexible in sharing the roles and responsibilities with their spouse. And this is really what gender synchronization is all about. Parents working together to prioritize the needs of the family regardless of traditional gender roles. So this case study was a practical application of family-centered care and strengths-based nursing, which are core concepts that are taught throughout pediatric nursing education. And these are used to advance gender equality and provide better outcomes for children. So here I have an example of one of our nursing students. PNEP uses a number of platforms, including social media and quarterly newsletters, and also local channels in Ghana, such as radio stations, to provide, to profile the expertise of PNEP students and graduates, and position them as future leaders and decision makers in policy and health system improvement. So because nursing is predominantly a female workforce, by raising the profile of nurses, we elevate the status of many women as professionals. And establishing nurses as specialists and experts in child health and giving them confidence to express concerns and share their knowledge, we help nurses, especially female nurses, be part of policy and decision-making for child health. So as I mentioned, here's one of our first graduates, Joyce, and she's become, since graduating, a strong voice for the health of premature babies and their mothers. She's done this through local campaigns and also talking on the radio. And Twitter has also given her an international platform to share her knowledge and passion for child health. And if this works, I have a video for you. No.
I'll play for you.
Great. Thank you.
Awesome.
I'm happy to be part of this course because this course will help me to build upon the existing knowledge that I've already acquired and help me to be a best advocate for the kids of my society. Also to get a special training in how to resuscitate birth asphyxia, and then to be a lecturer. Of course, those who are coming after me, I wanted to be a lecturer and then teach them to help change our society, especially when it comes to the sick kid. Thank you.
So I had the pleasure of interviewing all of our students entering the program. This was in the first week of school, and she was so passionate about learning and so passionate about sharing the knowledge that she's acquiring with others. And so since graduating, she has run support groups for mothers of preterm babies and has, as I said, spoken on the radio. So really being an advocate. And this is some of the qualitative data that Nick was talking about. Our gender equality strategy focuses on equipping and empowering individual nurses to be agents of change. And so here's an example of how a student challenged inequity by teaching parents to treat their girl and boy children equally. So here's what the student had to say. I had a boy and a girl as patients. The boy was plump and the girl was malnourished. The mother said that when they were babies, anytime she was breastfeeding the girl, the father would ask, "Won't you breastfeed the boy who'll carry my name? You're always giving it to the girl." It started from there, and now the girl is malnourished. So we called the father and educated him on gender. I told him, yes, the boy will carry your name, but so will your girl. They're both your children, so you should treat them equally. In this example, a PNEP nursing student has the knowledge and confidence to challenge their supervisor to provide more gender-sensitive care. So a man brought his child into the hospital, and the nurse in charge asked, "Where's your wife? Don't you know that women are better at caring for children? You can't bathe him, you can't care for him. Let your wife come around." So this is the student speaking, says, "I noticed the man's demeanor change, so I asked him why he was in the hospital with the child. He told me his wife had just given birth, so he had no other option than to bring the child himself. He said he would never come back to the hospital because the nurse in charge made him feel useless." I told this to the nurse in charge and explained why he came alone. "If you think there's something more he should do, you teach him. After all, he's human just like us. He can learn to take up certain skills for babies. So I imagine this was a challenging conversation for the nursing student to have with their supervisor. And we don't know how we don't know from the story how the supervisor responded, but anecdotally and through our evaluation data, we found that preceptors at clinical sites had extremely positive feedback of the PNEP nurses and often requested more graduates and more pediatric nurses to join their facility. So I will leave you with this quote from Frances, who is one of our amazing faculty members, who believes that pediatric nurses have a critical role in achieving health equality. And so with faculty like Frances, PNEP will continue to educate and empower individual pediatric nurses to be agents of change and advocates for gender equality in healthcare. And moving forward, we hope to build capacity at an organizational level with our Ghanaian implementing partners, as well as at a systems level in the education of health workers and development of pediatric nursing standards in Ghana. Thanks.
Thank you. So thank you very much to our panel. I actually want to do a time check because the time they're giving me here is different than the time I think I have. So I feel like we've got 25 minutes for this session. Yes? Okay, great. Good. Whew. Okay, because we could clearly talk all day about these things. So we'll get to some audience questions very shortly. I promise not to dominate the conversation as the moderator, but since I am the moderator, I'm going to pose a few questions. So very clearly, we talked a lot, or we started to speak about the alignment, for example, of the Project Gender Strategy with the Global Affairs Canada Gender Equality Policy and the Feminist International Assistance Policy. And so maybe SickKids has sort of addressed that, and so maybe I'll turn to Violet to say, how is the assessment aligned with some of those key priorities?
Thank you, Lindsay. As I said, the gender assessment that we did in Kenya was to inform the programming. So I keep telling her we should come to the third meeting after this one, then we tell you how we actually applied the knowledge. But already what we are doing is doing renovations in the health facilities. Remember the curtain I talked about? And trying to make the facility gender friendly so that men can feel comfortable. I remember a man saying he was queuing with mothers while waiting for his wife to be served, and the women were looking at him like, you're in the wrong place. So just having spaces where they can feel like they're part and parcel of their companions that are acceptable. Renovations as in making the theaters and the beds and some of the facilities. I had a picture there of the maternity. You can already see the first picture, sorry I forgot to point that out, was how the maternity, the delivery space looked like when we first went there and how it looks right now. And then healthcare worker training, just to be sensitive about that spouse who's made the effort to beat all this social stigma and show up. And being friendly with the mothers and reducing the barriers that they list about the supply side. But also outreach sessions. Like I said, our key informants included the imams, the leaders in the churches, the leaders in women organizations, the table banking group. So we're trying to do outreaches into the community to sensitize them more and more about the importance of male involvement, not just in naming the children and following through the phone, but being more like with the adolescent, the younger men, like I said, they're taking up more chores at home and escorting their wives against all this social stigma, but trying to say this is the right thing to do. It's not necessarily that they're the ones who are off the norm.
Thanks. So, I mean, I think for the assessment, we covered similar sectors or similar areas of inquiry as per the policy, but you can see that the learnings or the next steps can certainly be more complicated in terms of how we actually implement that. Mm-hmm. And so one of the things I wanted to follow up with SickKids is about the three priority areas around equal participation in decision making, control over resources and benefits of development, and realization of rights. How have you found actually addressing those things in practice? Are some of those easier to address through the strategy, or was there anything surprising?
Yeah, maybe I'll just quickly start by saying, I mean, each project is going to have its own strengths, so it's difficult to focus on all three. It's tough to say, what might be easier, what might be more harder. But maybe, Michelle, you've had some good observations about that.
Yeah, I think for our project, which the intervention was at the education level of healthcare workers, it was really discussion-based, and we were able to develop relationships, both the Ghanaian faculty and the Sick Kids faculty, build relationships with the students over the course of a year, and the students open up more and more, and you have richer and richer discussions. So I think advancing decision-making and like equal voices of men and women, we were seeing that in the classroom, and lots of fruitful discussion about equal rights. I think for us, the challenge was to get to the access part. So I felt like that was a little bit beyond our reach. Our immediate actions was to empower the students to be change agents and to give them the leadership and change management skills and confidence to have the conversations like the ones I mentioned. And that's how we would increase access, but it was a little bit down the line, I guess. Right. Yeah, it's harder.
And I think from Violet's presentation, you can see that dealing with social and gender norms is a challenge, but also really important. And so I think, for us, not only on the supply side, but also on the demand side, looking at how are we addressing some of these embedded norms in a way that is contextually relevant and acceptable in working with communities and families and individuals. So that's sort of the next phase of figuring that piece out. But it's a much longer term piece, right? That some of the other ones are very concrete. How do you respond to them? And others, I think, will take much more time and a little bit of trial and error. We'll figure it out. Okay, so we talked a little bit for access about learning and challenges and insights, and maybe from Sick Kids, you can tell us a little bit more about, what were the key sort of learnings or insights that you had from implementing this strategy, and were there any sort of similarities to what Violet was suggesting?
Mm-hmm. I mean, for us, at the onset, I think one of our challenges was trying to really tap into what is the local expertise like in Ghana so that we can make sure whatever we're proposing, whatever our strategies to address gender equality are, that they're locally appropriate, contextually relevant. So trying to really tap into that was difficult. I mean, it was helpful that we were able to engage our faculty who became more of a captive audience so that we could have maybe more challenging discussions in a safe environment versus more out in the open. So I think that was one of our key learnings and sort of something that helped us move things forward.
Yeah, from my experience in the classroom, I would just go and visit. I wasn't actually doing the teaching, but kind of being a fly on the wall. I would give a shout out to the youth, the students. They're in their 20s and 30s who were in the classroom mostly, and my key learning was to engage the youth, as we talked about yesterday, and let them teach each other. We saw really great moments when, a question would be posed to the class and someone would answer, and then that would spark debate because people didn't agree with the traditional answer with entrenched gender norms that somebody had given, and they would kind of challenge their peer. And we even had some apologies from students once they rethought things and opened their mind a little bit. They even had some apologies. So it was really cool to see youth teaching each other.
Mm-hmm. Maybe just one more thing I'll add is, because our programming is countrywide, we've also seen regional variances in gender norms. And what is the regional understanding of a more rural area like Tamale that has a different background, a different population, versus a more urban area such as Accra or even Kumasi. So trying to tailor our approach and trying to tailor some of the conversations. And Michelle talked about engaging youth. I think what that looks like in Tamale versus what that looks like in Accra was even different for us.
Yeah. Okay, my last question, because I know people are probably burning to ask questions, so sorry, is how would you propose to actually improve gender integration in programming based on what you learned? And I think, for access, for example, we talked a lot about the barriers and the challenges, but our respondents actually provided us with potential interventions as well and potential responses, and they came up with the ideas themselves, just like the students that you're working with understand best how to respond to their own peers. And so I guess, what's the next step? What's the way forward? How do we improve on this and to inform current or future programming? So maybe I'll go to you first, Nick.
Sure. So for us, I think Michelle mentioned, so we look at gender at 3 different levels. We look at it at an individual level, at an organizational level, and then at more of a system level. So we feel, we're very happy with kind of what we have been able to achieve to date at an individual level, which is basically, our residents, our faculty, and, the discussions we've been able to have. I think now we're starting to try to normalize some of these things in the institutions that we partner with. A lot of our program is very competency-based, so our students actually spend 70% of their time in a clinical setting. So it's working with our preceptors and working with the facility-based staff to make sure that, some of the examples that Michelle provided, that those types of responses become the norm, that those types of challenges to, more traditional responses to gender roles keep happening. And then I think at a system level, Michelle talked about, our desire to really introduce pediatric nursing standards. So by doing this, and this is something that the Ministry of Health has asked us to work with them on, we're really hoping we can embed some of these principles of gender-sensitive care at a system level so that, it goes well beyond PNEP. That it becomes, and that's our sustainability plan as well, that, by making this part of the policy of the ministry and really embedding it at that level, that we could see long-lasting change.
Yeah, if I can just add to that, I think all 3 of those levels are equally important, and I would encourage all of you to engage and commit at whatever level you're passionate about. Some people operate and convincingly argue for policy change and can engage with that stakeholder group. I've loved, my favorite part of my job was interviewing faculty and students, and through those one-on-one conversations and being able to elevate these individual voices and empowering people individually, I think that's really important too. I think of the cliche Margaret Mead quote that it's, what is it now? Engaged and committed individuals that make change. It's really important to be at the grassroots level as well.
Great, thanks.
Yeah, well, I think I had already given some of the steps we've taken around outreach sessions to engagement and health worker training to be sensitive to gender issues, but there's something maybe I didn't mention, I can mention now. Trying to encourage more women to get involved in governance. Remember I talked about the Community Health Committee, so that we have more women representatives at the health facility, because we have committees at the health facility, but also committees that are within the community. And in Kenya right now, we have what we call the 1/3 gender rule, all the way from parliament all the way down. So we're trying to have that in the university and everywhere else. So we're encouraging that kind of approach too.
Okay, so now I will open it up to questions, my goodness. And we're going to do rapid fire, which means questions, not preambles, short, and 1-to-1. So we're going to do 1 question, 1 answer. So if you can direct your question to an individual panelist, you get bonus points. Okay, great. So come on up, and we're going to do as quickly as we can and go from there. Go ahead.
Okay, rapid fire. This is to Michelle and Nick.
Can you introduce yourself?
Yes, my name is Mary Thompson, Canadian Red Cross. Yeah, I wanted to know, are you tracking as well when you talk about agents of change agents, empowerment, Are you tracking the impact of that, of those women and that change in those women on their work environments, as well as in the discussions you're having with the faculty and on their personal lives? And what are you finding?
That's a great question, Mary. I mean, I'll start by saying we probably don't get as far as their personal lives, but right now we're actually going through a series of key informant interviews where we're trying to really hone in at a facility level to talk to the people that our residents work with on a more broad level. So that includes their nurse in charge, that includes their colleagues, other people within their facility, to really understand, what has been the impact of our students as a whole, hoping that they'll talk about gender, but not wanting to bias them, obviously. So we are doing that actually as we speak right now.
I'm going to go.
Yeah, fast.
Well, my question, the more I'm involved in this international work, I understand how similar the indigenous practices are among many, many countries, among many, many groups. I'm a Bedouin. And I wonder, are we able really to share these best practices that implemented in this indigenous community based on their own best practices to indigenize this knowledge, validate it? Because I don't believe that any model that we bring from outside would be the best and would be owned by people if we are not validating some of the knowledge that exists. For example, mothers-in-law, it's all over that I see they are very strong. Why can't we make them the leaders for health promotion? If they are the strong ones and they have decisions making more than their sons. So the dichotomy of participation and decision making is not women doesn't have, men have. Elderly women have more decisions making abilities than their sons. So we have to think about this complex ideas, and please, the country donors should help these best practices to go through and be able to share with each other instead of inventing the wheels all the time. Thank you.
Do you want to respond to that? Or do you want me to respond to that?
Well, I think it's more of a comment, and I really appreciate that. Go ahead.
So one of the things that we're doing in the project, first I should say that our project is being implemented by local partners that are based in Kenya and in the region, and with the local government and local communities. So the gender assessment was designed with those partners and carried out with those partners in the communities. And the purpose was really to give us that kind of information, but also to get a sense from the community about what they recommend, right? And what they think are the ways forward. And it was really interesting, I think we found they had a lot of knowledge about what was expected by the health facility or what the community health workers were saying. And yet, there were all these other factors that were influencing behavior and practice that we needed to take into account. Yeah. Mothers-in-law are my personal and professional challenge, and so I think it's I should almost leave it there. But the interesting thing is we are looking at, in our behavior change communication approach, how can we engage mothers-in-law like we would engage traditional birth attendants? For example, in being engaged at the community health level to become agents of change and supporting their daughters-in-law and their own daughters to access care. So that's something we're also looking into. Thank you very much for that. Yeah. Okay.
Thank you. Wonderful discussion. My question is over to Nick. I saw a very great example of focusing on clinicians in capacity building. I have a question to ask you, because this is something that I see as a challenge, that defining quality of care is different for healthcare practitioners versus community. So was there a marrying midline for your project to look at community perspectives of how they define as their best health? And is your training strategy focused in some way of learning those behavior change communication strategies to instill into your core competencies so that even when you are not there, these clinicians can learn from the practices and change their behaviors accordingly? Because changing behaviors of healthcare practitioners, I am a healthcare practitioner, and I know it's very important to change their behaviors. We talk about community behavior change.
Okay, so we're going to take the question. Thank you. Sorry. Nick or Michelle?
You want to take that?
Sure. So a really important stage of PNEP was the content development, curriculum development phase. And that was done completely collaboratively with the Ghanaian faculty. So as Nick mentioned, they're a few faculty from schools of nursing in Ghana. There is also some nursing leadership in Ghana at the Ghana College of Nurses and Midwives. And so I think that our curriculum is something that PNEP is really proud of, that it's a merging of evidence-based clinical best practices into and with culturally relevant context. And so in terms of quality, like best practices, there are some really empirical evidence-based treatments and things. But when we're talking about family-centered care, what family-centered care looks like at Sick Kids in Toronto is really different than what family-centered care looks like in Ghana. But everyone, Ghanaian and Sick Kids faculty, all agreed that family-centered care, the concept, is important. What it looks like was up to the Ghanaians to create case studies or to, communicate like through role play and things, the practical aspects of that.
Great.
Yeah.
Thanks. So we'll take the last three people. We'll go still one by one, but I just wanted to let people know that we will take those people at the mic. Okay, which side? Over here.
Hi, Colin Beckwith from Nutrition International. We just wanted to perhaps turn on its head a little bit the question from this morning about qualitative data. As a quantitative person, how can I take this great work that you've done in qualitative work and reflect it in the quantitative data that I collect?
Yeah.
So I'm actually going to let Erica respond to that. She's standing right. No, she's like, no. I mean, I have comments on that, but Violet, you're the anthropologist. What do you have to say?
I teach a research methods class, and I've become fully baptized into believing in mixed methods. So I teach about qualitative, I teach about quant, but the last time I used quantitative was for my PhD and I left it there. Well, I use it in my programming and all that, but I focus a lot on qualitative because that's where there's a niche also in my country. But truth be told, I'm for mixed methods. When you use qualitative, like the example I've given you, what she said is we wanted to know from many voices and actually from the demand side, what's going on in your community? Why is this woman who has attended 4 ANCs giving birth at home? Why did she give birth in the facility, baby number 6, but for baby number 7, she's given birth at home? So these are questions you cannot answer. The how, the process, the why, using quantitative data. But you can actually use qualitative to do what I call free listing. You list as many things as you can find in the community, then you do what I call pile sorting. You sort them into things that make sense, like the 5 groups we had: decision making, practices, beliefs. You sort them into baskets, as I call it when I'm coding. And after that, now you can rank them. You can quantify as much as you want. And you can put that information in a questionnaire and administer it across the whole nation and get quantitative data. But at least you'll not have lost on the qual. And sometimes qualitative can also come at the end, not necessarily at the beginning. I use it a lot when I'm doing feedback of my projects, and I invite the participants back and I say, I found out this. What does it mean to you? And I collect so much information during that. Sorry, she's looking at me like your minute is gone.
No, it's okay.
But I'm for mixed methods. Honestly, I think when we go quant and forget quant, we lose a lot. But also, if I decided to just work with qualitative, I can't generalize. I can just tell the stories, and I love doing that.
The challenge, of course, is how we actually report the qualitative findings to our funder and to others, because it's not always easy to do so in the templates that we're required to complete. So I'm going to go to the next question.
Hi, thank you. My name is Kristen Ostling, and I'm with CanWatch. Thank you so much for such an inspiring panel today. I have a rapid fire question for all of the panelists. One key, in a nugget, piece of advice, a key message that you would leave us all with in terms of as we move forward on this journey towards gender equality and health. What's your biggest, best piece of advice for us in a nugget? Actually, even in a tweet, if you can. Very short. Thank you.
Awesome. So I'm actually, Kristen, with your permission, going to go to the question here, and then we'll end on that very inspiring note, hopefully. Okay.
Hi, Erica, AKFC. My question is really around timing and process. Both of you mentioned how important it is to do this early on, and often we can do it in year one after our implementation plans are approved. Sorry. So I guess the question is, if we had the opportunity to actually do gender assessments in a rigorous way during our design phase or pre, what would you have maybe done differently in your implementation? Would it have looked the same, or would you have been able to do something differently?
I mean, for us, it's difficult to say because we have the benefit of hindsight now, and I think our gender assessment was helpful. We conducted a gender roundtable, which gave us good insights. We wanted to. I mean, our strategy had to align with Global Affairs Canada's policy, so those 3 objectives. So, for us to develop and be aspirational in what we wanted to do from there was helpful. I can't say it would have changed because I feel like what we wanted to do was aspirational and it was quite big. It was about how we can actually make our programming fit that. So, it was great to do that exercise, but I don't know if it would have changed too much. It might have made us focus elsewhere, but I don't think it would have changed our overall, our 5 prongs or our objectives.
And when I look back, we underestimated how much time we needed. So I think I would factor in more time. I want to believe we captured different voices quite well. But the other thing was the ethics. This, in Kenya now, you have to get approval from an institutional review board and then from the national office. And we underestimated also how long that would take because the local IRB needs at least a month because they receive the protocol and send it out to 2 reviewers who must get back within 14 days. So you need getting to understand the context for research ethics and also getting trained moderators. Because I had to spend time training. We wanted to build capacity at the site, so I did not go with my students who I have already trained. So, and you can imagine training people to do one-on-one interviews and focus group discussions in a very short time and get them to collect data. It was a little bit challenging, but we tried. We worked with what we had. But I think lesson is, let's not underestimate how much time we need and the importance of having qualified staff to do this and to be able to analyze, to code the data really well and inform the program.
And ideally, one day, our gender assessments pre-project design will be funded.
That's true.
So, for the last question that we had, so what is one piece of advice in one sentence? I'll give you a second to think. One key piece of advice, lesson learned, way forward, inspirational moment. Who wants to start?
I can start.
Awesome.
Consideration of gender equality is critical to every aspect of global health, and don't let anyone tell you different.
I'll go next then. Tap into local agents of change and find those who are really dedicated on the ground to making this happen and seeing it through to the end.
And I'll say context matters. Listen to both the men and the women equally.
And I will say that we're often terrified by large gender strategies and gender equality challenges. And the truth is that you just need to map out what needs to be done and get started. Just start. And then we can keep going as we move forward. Thank you very much. And pleasure being with you this morning.